Are you ready to be connected? You're listening to the Insured Connection podcast by PICA Group, a pro assurance company, where we provide expert advice for your practice when you need it most. We connect you with industry leaders to discuss timely topics so you can listen, learn, and get back to caring for your patients. Now, let's connect.
Welcome back to PICA's Insured Connection. Tonight, we're going to be focusing on cardiovascular health and the foot and ankle. A non-healing wound or ischemic toe may seem like a local problem, but in many cases, it's actually the first signal of a systemic cardiovascular disease. I'm really excited to welcome our panelists for today's discussion on cardiovascular health and its impact on the foot and ankle. First, we have Dr. Daniel Fremed, a board-certified vascular surgeon with the Cardiovascular Care Group in Northern New Jersey. After completing his residency at Mount Sinai in New York City, he has spent nearly a decade focusing on advanced revascularization and the management of chronic limb-threatening ischemia with a strong emphasis on multidisciplinary limb preservation and collaboration with podiatric physicians and surgeons. We're also joined by Dr. Roland Ramdass, a board-certified foot and ankle surgeon with the Foot and Ankle Center, part of a multi-specialty group serving Northern Virginia, the Shenandoah Valley, and West Virginia. He's a teaching attending at the Inova Fairfax Podiatry Residency Program and serves on the board of directors for the American Board of Foot and Ankle Surgery. He's a past president of several professional organizations, including the National Board of Podiatric Medical Examiners and the Virginia Podiatric Medical Association. Dr. Fremed, Dr. Ramdass, thank you so much for joining us today. So when people really think about cardiovascular disease, they're thinking heart attack and stroke. Those are sort of the big hitters, right? But in many patients, the first clinical sign may actually appear in the lower extremity. I'm going to throw this one out to Dan. In 2024, the American College of Cardiology and the American Heart Association published a multi-society guideline that really emphasized PAD as part of a systemic cardiovascular disease and highlights really the importance of multidisciplinary care when we're trying to really prevent limb loss. How do you think clinicians should really think about PAD within the broader cardiovascular risk spectrum?
So, first of all, thanks for having me on.
Of course.
So, to think of PAD as just a leg disease, you kind of have to look at it as a big, broad process. Sometimes, as you mentioned, the global atherosclerotic process can first show up in the legs before someone ever has their first bout of chest pain after they shovel snow. Very rarely do you get atherosclerosis in just one vessel bed. So wherever it's manifesting, whether it's chest pain or leg pain or a toe wound, it needs to trigger alerts that there's a systemic process going on, and you should really trigger a thorough workup.
Often do you think, Dr. Ramdass, that lower extremity findings in your clinic, are you seeing that there are really some previously undiagnosed cardiovascular disease associated with?
Very often. I mean, we also know that about 50% of these patients who have a diabetic foot ulcer has peripheral arterial disease. So it's quite common. And I usually tell them, a foot ulcer is a heart problem that's just presenting in the foot because we know there's buildup of, plaques and so on. And I know the vascular guys that talk about the three-bed issues, which is the heart, the coronary arteries, the brain, your carotids, your cerebral arteries, and the limbs, the peripheral arterial, arteries. So therefore, it's one of those things that are, if it's affecting the lower extremity, it's also affecting the systemic areas and the upper body. It's the same plumbing system. So it's quite often, like I said, up to 20 to 30% of patients present with these ulceration. Up to 50% of them actually have underlying peripheral arterial disease that has been undiagnosed.
Yeah, I mean, we see that almost on a daily basis at the practice, right? I think one goes in hand with the other, unfortunately, especially if we're seeing ischemic changes to a toe. Our first kind of knee-jerk reaction is to look up, kind of look at the entire picture. What do you think, Dr. Fremed, is what would be your recommendation? I see a patient in the office, they have every acronym for diseases, right? We know that. And they have a small wound, a small ulceration. How far should we go to really investigate? Are we going to pan scan them or send them back to primary or cardiovascular and say, do everything? Or where's that limit go?
Well, no one should be doing everything. So I think that's the point of this whole talk and this whole podcast is, no one can do this alone. And no one should be doing it alone. But, what role each one of us plays in terms of helping, further the cause and to help get the patient worked up, can start as simply as just checking a pulse. And if there's a suspicion for PAD, then listen, send them over, send them to the appropriate specialist to help for the workup and the comorbidities associated with that. But it truly takes a team. I mean, you need multidisciplinary teamwork here in order to tackle this not just a foot ulcer, but a systemic problem here, because you're not going to be able to heal that ulcer with a terrible A1C. We're not going to be able to do surgery with terrible coronaries. And honestly, stents aren't going to stay open and wounds aren't going to stay healed with, crazy high cholesterol, blood pressure, and glucose. So you guys are probably are the first people to see a lot of these patients, but just as simple as checking a pulse or getting a history on a patient, I would have a low threshold for throwing them into the mix in terms of getting a workup done. There's so much at stake here that, often it's like, oh, I don't have anything wrong with me. I never see a doctor. No, I'm not on any medications. Of course not. But I got this wound on my foot, and just take care of the wound. And But
Yeah,
that's
we
the
get that a
first thing.
lot, right?
I
Dr.
completely
Ramdass?
agree. I think, like you said, Dr. Fremed, it's a multi-specialty patient-centric approach. So for us, when we see a wound that's not showing any improvement in 2 to 4 weeks, absent pulses or diminished pulses, wounds in the forefoot and the toes, I tend to get a lower threshold to refer out to you guys to get some screening. And then obviously if there's rest pain and those gross findings of ischemia, I think for us podiatrists, early detection, checking the pulses. If they're smokers, I think we should have a low threshold to send these patients off to get some testing. If they have known coronary artery disease, patients over 65, any patient over 50 with risk factors, as we know, should get at least for us, we send them off to get screening.
Like what you're hearing? Go ahead and subscribe so you never miss an episode again. Now, let's continue to connect on today's topic.
What are the things you're looking for on a physical exam, Dr. Ramdass? Let's say I'm a first-year associate right now out into practice. I'm overwhelmed. I don't know how to code. I don't know how to do anything.
So I think
Give me a checklist.
right, the key thing is, again, early screening and detection, decreased pulses, rest pain, nocturnal pain at night relieved with dependency, non-palpable pulses, wounds that are not healing, cold or cool, shiny, atrophic skin, absent hair growth, that rubrous, that mottling of the digits, thickening of the nails, delayed cap return. Those are the kind of things in a good clinical history, right? If they have a family history of coronary artery disease, how controlled is their diabetes? Have they been, regular on being checked up by their doctors? Those are some of the key things that they need to do. And I always tell them, prevention, an ounce of prevention is worth a pound of cure. So it's better you refer out early and come back as, a normal finding, and then you have peace of mind versus being reactive. And then we have, tissue loss and amputation. So I tell them, look for those things. But if they have any suspicion, send them off to your colleagues to get screening.
Yeah, I think that's a great point. I do believe the devil's in the details, right? So the clinical history tends to be the most important part. I found myself finding out that patients have had, have you ever had any surgeries? No, but they did put a stent in my leg.
Yeah, right.
And I'm like, that's important, right? We do need to know that. So really pressing that issue. I mean, if your gut is telling you that there's something wrong, you kind of have a feeling already. And I think Dr. Fremed knows because we work very closely together. I have very low threshold to send a quick picture like, hey, don't like it. Can they see you today? And we have the ability to do that, thankfully, right, in our area and probably in yours as well. What do you think is the best? And I'll ask this to Dr. Fremed. What do you think? Let's say you're in rural Kentucky, right? And there's really no specialists around. What objective perfusion test do you think may be the most helpful when we're assessing circulation to a lower extremity?
Ability to feel a pulse before you get into any like waveforms or PPGs or putting clips on people's toes, or feel for a pulse. In your scenario, if you take your first-year associate or your first-year podiatry resident, and if they can't feel a pulse, that should warrant an evaluation. Non-palpable pulses with any reason to be in a podiatrist's office warrants an evaluation. And, I have residents that aren't that confident in their ability to palpate pulses. A pulse should be easy to feel. If you can't, there's so much to lose by shrugging your shoulders and ignoring it. There's so many harmless, inexpensive, and quick ways of giving a binary 0-1. Is there disease? Yes or no? Is it significant? Yes or no? That you really don't have much to lose. So if you can feel a pulse, great, save the patient the trip over. But if you're struggling to feel pulses and you're not sure, there's so much to lose by not sending them over.
Yeah. Agreed. I mean, one of the things we employ in our office is handheld Doppler. We don't want to confuse, a weak pulse with our own pulse, right? And I think a lot of that is just years and years of seeing the same pattern over and over again.
It's funny. I sometimes get on my residents for over reliance on Doppler. That I said,
I know.
my pulses are palpable. Your pulses are palpable. If you can't feel it, that's not normal. I don't care what the Doppler is like. You
Yeah.
can either feel it or you don't. So
I guess, when you have the 350-pound lymphedema patient where there's no way you're feeling anything, it does provide some
yes,
usefulness. But,
yes.
I think, as you know, we have very low threshold of referring over because we do have the ability to do that. One of the statistics that always catches people's attention is that once a patient develops CLI, chronic or critical limb ischemia, limb-threatening ischemia, the 1-year mortality is 20 to 25%. The 5-year mortality can approach 50%. So we're really talking about a condition that carries a significant cardiovascular risk, limb loss risk, as well as life and death situation, right? When we're talking about cardiovascular disease specifically, any guidelines or sort of suggestions you can give, Dr. Fremed, on who to refer to first, right? I mean, what we're really trying to do at the Insured Connection is collaborate with other physicians, other clinicians to really not only give better outcomes, but to lower sort of our risk profile, right? Because a lot of these unfortunate patients have not so great outcomes. So what's your thought?
So I think that depends on the reason why they're in your office, right? Someone with a diabetic foot ulcer or a gangrenous toe is different than someone who's coming in for, I guess, more routine work, right? It's like, um, having never spent a day in your office, just let's say, a diabetic that's coming in for nail care,
Right.
I'm assuming is a patient you guys might see. No wounds, no rest pain, no ulcers, but their nails are really thick. They don't have pulses that you can feel, and they're known diabetics. I mean, if they're in the absence of a wound that needs to heal, there's probably not, or the absence of symptomatic PAD, there's probably not much that I can do, or would have any kind of benefit. But, if they have bad pulses, cardiology referral, endocrinology, go and talking to their primary, see what their last A1C is. I mean, the agents that my cardiology colleagues are able to put these patients on are like night and day just from 10 years ago. The primaries are able to initiate these new lifestyle modifying drugs that have such huge impacts on our patients that, if they're coming to you even for insoles or routine nail care, just even taking a second to feel for pulses or not may lead them towards some of the other specialties that can manage the comorbidities much better than I can. But that may trigger
Yeah.
something. Like, you guys are truly in the trenches, right? So a lot of times you guys will be the first point of contact between a patient and the healthcare system.
I'll add to that too. So yes, they're coming in for their routine care. That's when you have the time. You're doing something palliative, but just discussing with that patient, getting more of their history, and just kind of say, hey, when last you seen your doctor for your A1C? When last you've seen your doctor? Or how well is your sugar? Or any issues with your eyes? Because that's when it's is there to discuss with the patient, sort of hash out some issues, and then refer appropriately, like Dr. Fremed said, whether it's to the endocrinologist, whether it's to the cardiologist, to the vascular doctor. I think that's a time to really educate patients while doing that routine care is critical for our colleagues in our practices.
Yeah, 100%. I think that is the captive audience time
Yeah.
where we can actually talk. But some of the patients actually never knew that they would be candidates for certain life modifying drugs, right? Patients with an A1C of 12, I had a patient who was 100 units of insulin at night, plus regular throughout the day, and then had a simple conversation about, other drugs as a potential option, already had a history of an amputation, and now is on 2 units of insulin with a 47-pound weight loss and A1C of 5, which unheard of, right? And that's just a 1, 2, 3-minute conversation about a drug that we all know about, or drug class that we all know about. And we've seen such a big shift, right? A change in the health status of some of our patients. And it's amazing. I think when we're thinking about sort of cardiovascular and foot, right? I don't think they're mutually exclusive, obviously. We know that. But I really want to think about, what do you think is like the single most important step that clinicians can take to reduce this preventable limb loss in a patient who has cardiovascular disease? Now, for Dr. Fremed, what do you wish that we would recognize sooner? We know palpate pulses, don't use a Doppler. I get that. But what else? Is there any sort of secret little pearl that you could give us?
I mean, that's really it. It's not waiting too long on an ulcer to see how it heals, or waiting another week, or waiting 4 weeks, and maybe we'll try a graft first. And it's recognizing that this isn't just a venous stasis ulcer, that if half the wound is black and it's the tip of the toes, these punched out lesions there, that it's a different beast than a routine run-of-the-mill wound. So I just think early recognition and a low threshold for referral, because the earlier we can get in there, and we can save a lot more tissue and prevent a lot more tissue loss.
Want to receive a monthly newsletter with topics from the Insured Connection? Head over to picagroup.com/Insured Connection and join our email list to have it delivered right to your inbox.
Yeah. Dr. Roland, now to you. Dr. Ramdass, sorry. When you see a patient with a wound that isn't progressing, let's say it's a diabetic foot wound, let's say it's a venous stasis wound, right? Again, another circulatory issue. How quick are you to refer for venous stasis versus diabetic foot?
So both of them. I mean, I think within 2 to 4 weeks, if you're not seeing greater than 50% improvement in the wound for a venous stasis ulcer, for example, with compression and appropriate wound management, you don't see satisfactory improvement. And the algorithm or the recommendation by the American Diabetic Association is 50% improvement in 4 weeks. If that doesn't happen, you have to take a step back, right? Why is the wound not healing? Is it ischemia? Is it pressure? Is it infection, right? And you have to have that keen sense of suspicion, early detection, and early referral, I think, is critical to prevent these wounds from becoming, devastating issues that can lead to amputations and so on. We also know that when you have a team approach, the studies have shown 40 to 80% reduction in any limb salvage or limb loss if you have a multi-specialty approach in these patients. So I think, again, it comes back to whether it's your cardiologist that you're referring that's doing your vascular intervention, or your vascular colleagues who are doing your intervention. I definitely need to send them off to get somebody to do some testing. And when it comes to testing too, from our standpoint, is after pulses is getting TCOMs, because we know that TCOMs and toe pressures, these patients have calcified vessels. So we got to be careful with, abnormal ABIs being elevated and being falsely elevated. So I think getting your toe pressures and TCOMs are also critical too. I like to get them just so I can get a baseline, especially in the older patients, because I've got where I practice, it's in a rural area. I know you guys may not have that, but these guys are, sold to the ground. They're just, if you get them in and you explain to them and they do it, I think it's better, because they don't come to the doctors often. So when they come, something is up.
Yeah. That's the pour some dirt on it or some tussin.
Yeah, right. Yeah, but by the time they're coming to you, half the foot's falling off, and then they're like, "Hey, doc, I need to go back on the farm." So that's when you got to really sit down and educate and be comprehensive with these patients.
Yeah, it's so interesting to see. I mean, you're in a rural area, and we're probably not, more suburb, right? Suburb to small city, I guess. And we still see patients who've waited way too long, right? We probably see the same foot that comes in on a Friday night, usually a holiday weekend, something that the patient sat on for a couple of days thinking it'll go away. Part of the reason we want these conversations to happen is really, we want to think about the foot and ankle as sort of the gateway, right? The foot and ankle can demonstrate so many other pathologies in the entire body that, of course, we're frontline. We're the first ones to see these people. A charming personality like Dr. Ramdass can, pull out information from patients and be able to have them get the care they need. Dr. Fremed can say, listen, this is what we're going to do. We need to do this, or we're going to fix, this vein, or we're going to stent, or we're going to do some sort of endovascular procedure. So we have a lot of tools in our toolbox. One of the things that I always talk to my residents about, and it's from Atul Gawande's book, is like the checklist manifesto. If we had to create a checklist, right? First visit, patient has a non-healing wound, right? We don't know the etiology. Well, we know it's probably diabetic or PAD, fine, but we don't know how long it's been there, if they've done anything, are they rubbing tussin on it? We don't know. What's our checklist, right? So we know palpable pulses, yes, no, right? And I know, Roland, you said not 50% improvement in 4 weeks, then we go back, right? And we look at all the things, right? So we obviously say circulation, infection. These are the things we're ruling out. Pressure, offloading, compliance, right? Anything I'm missing, because we want this to be high yield for our audience so they can take some pearls home and back to their clinics, wherever they're practicing.
I think one of the other things I would add, in addition to what we just talked about, those objective findings is, recognizing the social determinants of health. So a lot of these patients, as we talked about, some are, non-compliant because of lack of transportation, lack of, education, lack of home support at home, right? So we're telling them, hey, you need to offload this wound, but they're living by themselves. They have to go up 2 stairs. They're still working on it. So I think recognizing that is also important, and documenting it appropriately, I think is critical, and assessing if we can implement some of the other resources, whether it's social worker, whomever else, or like in our area, there's these free transportation for medical support and so on and so forth. So that would be my other thing to just add to the audience is, in addition to your clinical evaluation, what else can we do? I think is just recognizing that and assisting and insisting on them getting these referrals and helping them to get to those referral appointments. Because we can tell them, go to Dr. Fremed, but if they don't have transportation, they're not going to listen to us, or at least they can't.
What do you think, Dan? Any other things I should add to my checklist?
No, I think that sums it up perfectly. You get a comprehensive view of the patient. You can't, you can't put patients on a conveyor belt, right? You can't. Every patient, especially with a lot of these comorbidities, you got to get to know them, right? You have to know what their drive is, what their home situation like is, what their work situation is. I think that affects a lot of how the conversation goes in terms of the care that gets offered, the planned treatments, or really what the goals of the patient's care are. So you got to get a sense of who this patient is, what they can do, what they can't.
Love it. So I want to just say a couple of closing words. Limb loss is obviously rarely just a foot problem. It's often the result of systemic cardiovascular disease. Recognizing that connection early and working collaboratively across specialties is key to preserving both limb and life. I want to thank you guys, Dr. Fremed, Dr. Ramdass, for joining us tonight. This was an awesome conversation. This is exactly what we are trying to do at PICA and the Insured Connection, where we're connecting physicians to lead to better care. Thanks so much, guys. Have a good night.
Thank you for having us.
Thanks for having me.
And that's it for this week's episode. But let's continue connecting. If you're enjoying the Insured Connection, don't forget to leave a review on your streaming platform and subscribe now so you can connect with us each time we post a new episode. To stay connected with us throughout the week and to tell us topics we should discuss on future episodes, go to picagroup.com/insuredconnection.